are. And we'll talk about the anatomy of the extracranial carotid and carotid.
Sure. So should I go ahead and share my presentation?
Yes, sure.
Okay, can you see the screen?
Yes, perfect.
Hello?
Perfect.
Okay. Okay, so this is Dr. Yasir Khaber. I am working as a consultant neurospinal surgeon at Hyderabad, Pakistan. Today, I'm going to be talking about the anatomy of the extracranial carotid artery and the carotid sheath. So as you all can see in this, as you all can see in this picture depicts the gross dissection view of a cadaver. In this picture, we can appreciate the various vascular structures that we usually encounter within the neck region when we are dissecting it out. So this is a bit within the center. This pinkish structure is actually the thyroid gland. Here we have got the thyroid cartilage cells that are coming from the thorax into the neck. This region would be the root of the neck. You can see that on one side we have got this clavicle intact and various muscles attached to it. On the other side, however, we have cut out the bones and we have exposed these pectoralis major muscle to see the structures lying beneath. Today, as you all know, we are dealing with the various major vessels within this region. So we will be talking about these vessels specifically. This is the sixth structure labeled is the brachiocephalic trunk, which is dividing into the common carotid artery. So the eighth structure is the common carotid artery. This one then gives rise to the external carotid artery. So this is the external carotid artery, and this structure labeled 17 is actually the internal jugular vein. So let's just simplify it to a schematic diagram. Now you can see in this picture, in this schematic diagram, there are various structures that we just described. There's this glistening white structure that is surrounding these neck muscles. This glistening white structure is part of the deep cervical fascia. So when we talk about deep cervical fascia, it is actually composed of 4 parts. These 4 parts are the investing layer of the deep cervical fascia. This is the investing layer of the deep cervical fascia that is labeled within the red. And this, as the name suggests, is an investing layer. So it invests around the entire neck region. Then we have got this blue region, blue area. This blue part is known as the pretracheal fascia. You can see that this is the trachea, this is the esophagus, and it's lying anterior to the trachea. So that's why it's called the pretracheal fascia. We have got the vertebral bodies behind, and just anterior to the vertebral bodies, we have got this yellow layer that is known as the prevertebral layer of the deep cervical fascia. And then the structure that we want to discuss today is this layer that is labeled in the green. That is the carotid sheath. Carotid sheath is actually labeled as a part of the deep cervical fascia, but actually it's a loose areolar matrix that is surrounding these vessels. And you can see that in reality, this is not actually a division. There's no partition in the living being. In the living beings, these layers are actually communicating with one another. So when we talk about the living beings, we have got this green structure is actually communicating with various structures. You can see that on the medial aspect, it is just getting blended with the pretracheal layer of the deep cervical fascia. On the posterior aspect, it is blending with the prevertebral layer of the deep cervical fascia. On the anterolateral aspect, it is blending with the investing layer of the deep cervical fascia. So what is actually within this carotid sheath? You can see 3 structures in this picture that are clearly lying within the carotid sheath. One of the structure lies medially, just beside the pharynx. This medial structure is the artery. And then one structure is lying laterally, that is the vein. And in between the artery and the vein, we have got this small structure, that is the nerve. So this small structure is actually the vagus nerve. The artery could be either a common carotid artery below the thyroid cartilage, or it can be internal carotid artery above the level of the thyroid cartilage. And this structure is the internal jugular vein. So the internal jugular vein lies laterally, whereas the carotid artery lies medially. So coming back to this previous picture, so this glistening white layer that we are seeing in this picture is actually the investing layer of the deep cervical fascia. Then we can see that various blue colored structures that are the veins. This most superficial vein is the external jugular vein. We won't be talking about this one in detail. However, on the other side, that is on the right side in this diagram, we have actually removed this investing layer of deep cervical fascia, and we have removed this muscle. And this muscle is the sternocleidomastoid muscle that we have removed. And once we remove this investing layer in the muscle, we can see various deeper structures that we are going to talk about today. One of them, as we previously discussed, the laterally lying structure is the vein, that is the internal jugular vein. And then we have got this artery that inferiorly is the common carotid artery, superiorly it would continue as the internal carotid artery. Then we have got various nerves in this region. Obviously, vagus is not visible in this diagram. We can see this trapezius behind. We can see the sclerae muscle behind the internal jugular vein. We can see in the midline various strap muscles. One of the most important strap muscle is this muscle, that is the omohyoid, and it serves as a landmark for the internal jugular vein. So this is the tendon of the omohyoid. This one would be the inferior belly. This one would be the superior belly of the omohyoid. So this omohyoid muscle, the tendon, actually serves as a landmark to this structure, that is the internal jugular vein. So this structure is actually traveling from the root of the neck, that is from the thorax up till the base of the skull. Various structures which travel within the carotid sheath have different endpoints. The internal jugular vein would obviously start from the jugular foramen as a continuation of the sigmoid sinus, and would go on to empty into the main venous channels, that is the superior vena cava. And the common carotid artery would actually begin on the one side from the brachiocephalic trunk, and from the left side from the arc of aorta, and would terminate by dividing into the external and internal carotid artery. So now this diagram is an schematic diagram that will help us learn about the relationship of various structures that are part of the carotid sheath. As we previously described, there are three main structures within the carotid sheath. One of them is this vein that is labeled in blue. This is the internal jugular vein. Then we have got the common carotid artery. Mind it that common carotid artery and internal carotid artery both lie within the carotid sheath, whereas the external carotid artery actually is not a part of the carotid sheath and lies superficially. And then we have got these yellow structured nerves. It is not only the 10th nerve, the vagus nerve, that is a part of the carotid sheath, but over the course of the carotid sheath, various nerves enter and then exit the carotid. So all some specific level. So whenever we as neurosurgeons are doing dissections within these regions, when we are doing endarterectomies or approaching these vessels, we should be careful about these nerves. So let's just briefly go over the course of the various cranial nerves that are part of it. So this is the vagus nerve, as you can all see. The vagus nerve, this is the inferior vagal ganglion, a swelling of the vagus nerve. And then the vagus nerve is also related to the other cranial nerves in this region. This you can see is the 12th cranial nerve. I'm starting with the 12th cranial nerve because it is important, especially during the endarterectomy. Its course is important. You can see this is the 12th cranial nerve coming down. Then it passes inferiorly below this loop of the posterior auricular artery, passes deep to the posterior belly of the digastric muscle, and then takes a sharp 90-degree turn forward. So here would be the tongue and the jaw region where this hypoglossal nerve has to go. It has to go to supply the tongue. It's coming from the hypoglossal canal. So once it takes this 90-degree turn, it is actually crossing anterior to both the internal carotid. Glossal nerve lies superficial and crosses anterior to the internal carotid and external carotid artery before passing into the jaw. So this is an important relation, especially when you are doing dissections in this region. You have to be careful about it. Then we can see the accessory nerve. This is the 11th cranial nerve. The accessory nerve has got a sad story. It has two portions, the cranial and the spinal portion. We know spinal portion arises from the spinal part. The cranial portion arises from the nucleus ambiguous, but those cranial fibers are actually borrowed to be passed on to the vagus. So you can see that here it passes these fibers back to the vagus nerve, and then it will supply via this pharyngeal branch. These fibers which are coming from the cranial part of the nerve will go to supply the muscles of the pharynx other than the stylopharyngeus and muscles of the palate other than the tensor veli palatini. Another important nerve is the glossopharyngeal nerve. You can see this glossopharyngeal nerve is actually lying in close relationship with the stylopharyngeus muscle, passes below the stylopharyngeus muscle, and goes on to supply the pharynx and all the other muscles of the pharynx other than the stylopharyngeus. You can also see that between the internal carotid artery and external carotid artery, there are three structures that are passing over here. One of them is this stylopharyngeus. The other one is the glossopharyngeal nerve. And the third structure is the pharyngeal branch of the vagus nerve. So these are the structures which actually separate the internal carotid from the common carotid artery. And another identification point when we are doing dissections in this region within the neck does not give off any branch at all. So it is the branchless artery within the neck. It is going to give branches only after it enters within the carotid canal and going towards the intracranial part. However, the external carotid artery has got various branches coming off. You can see here that there are branches coming off the external carotid artery, as we will discuss later on. And then we have got another important branch over here. You can see this root that is coming posteriorly and turning around the internal jugular vein. This is the posterior or the lower root of the ansa cervicalis. And then we have got a superior root of the ansa cervicalis. So the superior root of ansa cervicalis travels on the artery, whereas the inferior root travels around the vein, and they come and join together in front of the artery. These will supply the strap muscles we just described. What are strap muscles? These are the muscles which travel between the sternum and the thyroid cartilage. They can be thyrohyoid, sternohyoid kind of muscles. The superior root comes from the hypoglossal nerve. You can see that it is arising from the hypoglossal nerve, whereas the inferior root comes from the C2, C3 rami that are located over here. So just going to the surface marking of these structures, the common carotid artery starts at the level of the sternoclavicular joint up till the upper border of the thyroid cartilage. This marks the level of the C4, upper border of the C4. This is the surface marking of common carotid. From the upper border of C4 up till the tragus, we have got, if we draw a line, this one would represent the internal carotid, whereas from the upper border of the C4 behind the angle of mandible, if we draw a line, then it would represent the external carotid. So this was about the surface marking. So just in this schematic diagram, I'm going to trace that how these arteries are actually originating. As you can see, this is the arc of aorta within the thorax. On the right side, we have got this brachiocephalic trunk. On the left side, we have got two branches. Common carotid arises separately, subclavian arises as well. Whereas on the right side, the brachiocephalic artery. So this is where the common carotid is actually, this is the origin of common, lies lateral to the thyroid gland and behind the of the thyroid gland. This nerve over here, internal jugular vein, that is actually draining along with the subclavian vein to form the right brachiocephalic trunk before emptying into the vena cava. So this is where the carotid sheath actually is starting. And from here, the carotid sheath starts. You can see that the internal jugular vein lies laterally. The common carotid artery lies medially. The vagus nerve in between these two. And then it ascends of these structures. You can see that on the left, you have got this thoracic duct just at the origin. You can see the phrenic nerve and you can see the anterior scaneus muscle, which are located in a posterior relationship. So we are coming a little bit up and we are following this carotid sheath further upwards. We are going towards the base of the skull. So this is the external notch. This is the same brachiocephalic trunk. In this one, we have removed the venous with them off. The very important posterior relation is of this sympathetic trunk. The sympathetic trunk itself is not a part of the carotid sheath, but it lies deep to the carotid sheath. And this is the sympathetic trunk which travels behind the carotid sheath and the artery. You can see other branches of the thyrocervical trunk also, but they are not important. Let's just ignore them. But these are the three main structures that we have to follow: the vein, the artery, and the vagus nerve. Thyroid gland has been retracted to give you a better view of the common carotid artery. This is another dissection diagram. Now that you have a view and understanding of the schematic diagram, you can understand this one. You can see that this one is the brachiocephalic trunk. It would go on to give rise to the common carotid artery. Finally, at the level of the thyroid cartilage, this common carotid artery would further continue as the external carotid artery. I'm calling this point 8 as the external carotid artery because I can see the branches coming down. This is the superior thyroid branch, superior thyroid artery of the external carotid artery, and this one is the common carotid artery. I can also see a nerve that is going posteriorly. Previously, we discussed this, that the nerve that is leaving this carotid sheath posteriorly and going posteriorly is the accessory nerve. So this structure labeled as 1 is the accessory nerve. Another schematic diagram. This is the lateral view now. You have got the sternocleidomastoid intact, and you have got these strap muscles anteriorly. You have got the sternohyoid, you have got the thyrohyoid, and you can see that in this triangle, that is actually known as the carotid triangle for the carotid sheath, anterior to the sternocleidomastoid, behind the strap muscles, above bounded by the posterior belly of the digastric muscle and the stylohyoid muscle. This is the carotid triangle with it lies the carotid sheath, and the structures of the carotid are very easy to identify now. And medially, we have got this internal carotid artery and the external carotid artery. This one is the external carotid. This one is structure that is located deep is the internal carotid, and this is the vagus nerve that is traveling. You can also see that as I previously described in this diagram, the hypoglossal nerve crosses anterior to both, is coming in between and is crossing superficial to both internal and external carotid artery before going deep to the mylohyoid muscle and superficial to the hyoglossus muscle, and is going to supply the muscles of the tongue. So this relation is to be kept in mind, especially of the hypoglossal nerve. Then these are branches of the cervical plexus. We are not going to discuss it. Let's just keep it simple. But we have to see this important structure that is living behind the sternocleidomastoid, behind the anterior scalenus muscle. This is the brachial plexus. So again, a further deeper dissection of the same diagram. We have now removed the sternocleidomastoid completely out of the view. We have cut down this omohyoid muscle as well. Now we can see these structures more clearly. We can see the entire course of the vagus nerve now. This is traveling in between them. We can see the internal carotid artery. We can see this external carotid. We can see the branches coming off the external carotid. We can see the ansa cervicalis that we previously described. This is the superior root of ansa cervicalis. This is the hypoglossal nerve from which it is arising. We said that the posterior or inferior root comes from the cervical plexus. So you can see that internal jugular vein is actually posteriorly related to various nerve structures. Now I'm going to describe these nerve structures. It is posteriorly related to this structure. This nerve that is coming out of the middle scalenus muscle. This is anterior scalenus. This is middle scalenus. So this is the cervical plexus coming out of middle scalenus. Inferiorly, we have got brachial plexus in between the anterior and middle scalenus. And then we have got this very important famous nerve, C345, keep the diaphragm alive. This is the phrenic nerve that is traveling just superficial over the surface of the anterior scalenus muscle. So these are the nerves which are in posterior relationship of the internal jugular vein. The C2 and C3 give a rami to form the inferior root of ansa. Superior root forms in front of the artery, the inferior root forms in front of the vein, and the branches go to supply these strap muscles. So again, we are just doing a schematic diagram, then getting an understanding of the dissection one as well. So this is a dissection one in which we can see the vein, that was the internal jugular vein. We can see the common carotid artery, and we can see the external carotid artery. We can see the posterior belly of digastric over here. These are the strap muscles. This is the omohyoid. You can see the omohyoid tendon crosses the vein So the tendon of the omohyoid is a mark for identifying the internal jugular vein. You can see this structure labeled as 1 that is going posteriorly along the edge of the internal jugular vein. This structure that travels posteriorly is your accessory nerve. You can also, look closely, you can identify this structure, the hypoglossal nerve. You see, the hypoglossal nerve is crossing superficial to the external carotid and the internal carotid before going on to the mouth area. So another dissection picture, this one shows the relationship of the artery more clearly. This is, as we previously described, the internal jugular vein. This is the omohyoid muscle. This is the superior belly of omohyoid, tendon, inferior belly of the omohyoid, internal jugular vein. This is the common carotid, labeled as 3. Then this is the external carotid. The internal carotid goes deeply. The external carotid is not a part of the carotid sheath. It has various branches coming off anteriorly, superior thyroid, and the lingual artery, and this one is the facial artery. You can see this one is going and turning around the angle of the mandible and going upward. So you have got those branches of the external carotid artery, whereas the internal carotid artery and internal jugular vein and the vagus nerve are traveling over here as a part of the carotid sheath. So this is the carotid sheath in a dissection specimen, completely exposed all the way to the base of the skull from the root of the neck. Again, we have got these various nervous structures we previously described, the brachial plexus root, the cervical plexus root coming posteriorly in posterior relationship of the internal jugular vein. So another schematic diagram. Now this one tries to help you understand the external carotid artery. See, this is the level of the superior border of the thyroid cartilage. Common carotid is dividing into 2 branches. This portion of common carotid is slightly dilated and is known as the carotid sinus. It actually works as a baroreceptor. And here we have got the carotid body lying down, which work as a chemoreceptor. Both of them are supplied by the glossopharyngeal and the vagus carotid branches of the glossopharyngeal and vagus nerve. We can see that the author has actually retracted the carotid sheath away with the help of this retractor. So he's pulling away the internal jugular vein, pulling away the internal carotid artery, and along with it, he's pulling away the ansa cervicalis and the vagus nerve. Mind it, I would not recommend to do this in a live specimen. And this external carotid artery can then be visualized completely. You can see this is there are various branches of external carotid artery. An easy way to remember them is that 3 of them come anteriorly, the superior thyroid artery, the lingual artery, and the facial artery going along the loop along the jaw. Then 1 of them goes medially. This is the ascending pharyngeal artery that goes medially. 2 of them go posteriorly. One of them is this one, posterior auricular artery. Another one is this, the posterior occipital artery. And then finally 2 terminal branches, the internal maxillary artery and the superficial temporal artery that all the residents love to burst during the decompressive surgery. Then we have got the various nerves as well. The accessory nerve passes lateral, superficial to the internal jugular vein, goes back. We have got this hypoglossal nerve. Very clearly, you can see that hypoglossal nerve comes down and passes anterior to both the internal carotid and the external carotid and goes on to pass deep to the mylohyoid. So again, dissection specimen, the same thing has been depicted. This 4 is the common carotid artery, very easy to understand now. This is a dilated portion of the common carotid. So this is the carotid sinus. This one is with branches. This is the external carotid artery. This one without branches is the internal carotid artery going deep down. Obviously, the vein has been removed in this specimen. So we can see this 32 labeled structure. This is the vagus nerve. And we can see the hypoglossal nerve over here as well, coming to pass into the jaw. Now, this is structure I just put in this picture to give you an understanding of the branches, but I have already described the branches of external carotid artery. And I think you guys have got an understanding for that. And this picture again shows those branches like superior thyroid, lingual, facial, they are anterior. These are the 2 terminal branches. Then we have got a posterior branch and we have got a medial branch, that is the ascending pharyngeal artery. One mnemonic to remember, it was Salpopsy. But if you remember how I told you, I think you won't miss it. So internal carotid artery, we already described, has got no branches within this region. As a smooth artery goes all the way. The initial portion of the internal carotid artery would be dilated as a continuation of the carotid sinus. The remainder lies within the carotid sheath. Thank you very much. That was what I wanted to discuss about the external carotid artery and the carotid sheath today. If you guys have any questions, kindly do let me know.
Any questions? I think there is no question in the chat box. You can write to the chat box and the Professor Kiba can answer. At the end of the session, if they write anything, we can answer. And now I will share the video of the Professor Selda. Thanks, Kiba, your detailed explanation of the carotid artery. And now I will share the video of Maria Paris-Selda.
Thank you very much for the invitation. My name is Maria
Could you hear?
Professor of Neurosurgery at Mayo Clinic and Director of the Surgical Anatomy Lab. Thank you very much. We are going to discuss today the surgical anatomy. Thank you very much for the invitation. My name is Maria Paris-Selda. I'm a Professor of Neurosurgery at Mayo Clinic and Director of the Surgical Anatomy Lab. Thank you very much. We are going to discuss today the surgical anatomy of the head and neck muscles in this neuroanatomy series. And we're going to discuss two areas, the areas of head and the area of the neck. And these areas are divided by a line between the inferior aspect of the mandible and the occipital protuberance. And this is the osseous structure, the cranium. Laterally. And if we pay attention to the C1, C2 areas, we can see the C1, C2 or atlantoaxial joint that are just medial to the vertebral artery. And then the vertebral artery, as it ascends through the foramen transversarium, it turns back over the lateral mass of the atlas, over the groove for the vertebral artery. And this is how it turns and hugs the lateral mass of the atlas to become intracranial and intradural. So this is the posterior aspect of the neck, where we can see the occipitocervical junction with C1 and C2, and the segment that is just lateral with the C1, C2 joint, and then the segment that goes around the lateral mass of the atlas in the sulcus arteriosus here to become intradural. This is a detail of that turn of the vertebral artery, and just of note, we're going to see in the cervical vertebrae the anterior portion with the vertebral artery, and then posteriorly the cervical vert. So if we go now, we are going to start layer by layer the muscles of the neck region. And here the ear is posterior, and we can see an oblique view of the neck where we have dissected the subcutaneous tissue and the platysma coli. The platysma is a very thin layer of muscle, and we have the fascia that we have removed. If we divide and we elevate this region, then we see the platysma that has been reflected and divided superiorly. And these small branches that are the branches of the facial nerve is the cervical branch of the facial nerve that innervates the platysma coli. We see general anatomy as well. This is the parotid gland and the submandibular gland. And then we're going to go a little bit in detail through the muscles, but we can see in depth, you can see the common carotid bifurcation. And here, for instance, we can see the vagus nerve. Then looking at the facial nerve, we can see the parotid gland here. The facial nerve travels in between the deep and superficial lobes of the parotid gland. And we see several branches here that go to the musculature of the face. And we want to pay attention. This is the cervical branch that we saw earlier. And we want to pay attention to the marginal mandibular branch. Also, part of the facial nerve that innervates the entire aspect and the corner of the lip. And this is important, has an important surgical significance in head and neck surgery that we are going to see. Here we see in depth, in the deeper layer, we see the masseter muscle, we see the buccinator muscle, and then superficial to them, we see the facial muscles that we will again look at it in detail. This is the marginal mandibular branch, and this is the bone of the mandible with the platysma colli that has been reflected. And usually an incision, the incision is safer about 2 centimeters below the angle of the mandible to avoid damage of the marginal mandibular branch of the facial nerve. Here we see also important the digastric tendon here, the posterior belly of the digastric, and then we see also the facial artery coming this way, and this is the submandibular gland, and we can see also the carotid, the vagus nerve, and ansa cervicalis, and this is the internal jugular vein and the sternocleidomastoid muscle. So a lot of different and important anatomy that we can see in this picture. But now if we want to go a little bit in detail through the muscles of the neck, we have, and the neck is divided in triangles. And when we look at the triangles of the neck, we have an anterior triangle and a posterior triangle. The anterior triangle and and they are both divided by the sternocleidomastoid muscle. The anterior triangle of the neck is located between, or is referenced between the midline, the mandible, and the sternocleidomastoid muscle. In this triangle, we have 2 compartments, the suprahyoid compartment and the infrahyoid compartment. They are both divided by the plane of the hyoid. And then we're going to further divide those. The posterior triangle of the neck is referenced between the sternocleidomastoid muscle, the clavicle, and the trapezius muscle. Going more into detail, in the suprahyoid space, we have this space divided by the digastric muscle, anterior and posterior belly, into the submental space that is filled with ganglia, fat, and muscle, and the posterior aspect of the submandibular triangle, in which if we dissect and retract the submandibular gland, we can find the hypoglossal nerve in the vertex of this triangle. In the anterior triangle of the neck, in the infrahyoid compartment, we can divide this by the omohyoid muscle into the muscular triangle, which is located here anterior-inferiorly, and the carotid triangle that is located posteriorly. The muscular triangle, we can see here, this is the thyroid cartilage, and we can see the sternohyoid muscle, and laterally the sternothyroid muscle. So these form the muscular compartments, and we can see the carotid triangle, in which we can see the carotid bifurcation. There are many other anatomical structures that are located here, but the main one that gives the name to this triangle is the carotid bifurcation. We can see also in this anatomical picture, we can see the ansa cervicalis here that innervates those muscles as well. And we see the cervical plexus, and then we also see here posteriorly the brachial plexus. This is the internal jugular vein, and this is the carotid artery that are located here. And then we can see also the vagus nerve. Right here posteriorly. This is more of a surgical view of these anatomical structures. So we can see the inferior aspect of the mandible, you can see submandibular gland and the facial artery, and here the nerve, the omohyoid. Here, I'm sorry, this is the muscle, the omohyoid muscle, and then this is the thyroid cartilage. We can see the sternohyoid muscle, the sternothyroid muscle laterally, and here the carotid bifurcation in the carotid triangle, and here we can see when we remove all this musculature and we are in the prevertebral space, we can see the longoscoly muscle, which is located here, and then we can see the carotid bifurcation. Here, the external carotid has been divided, and the nerves that are in this vicinity that of note is that we can see here the 9th cranial nerve. This is the 12th cranial nerve, and this is 10 or the vagus. We can also see the 11th cranial nerve. So this is a region with different delicate and anatomical neurovascular anatomical structures. Well, if we elevate and we divide and elevate the sternocleidomastoid muscle, and we can see better the whole area of the omohyoid muscle. We can see here the brachial plexus, and the brachial plexus located between the anterior scalene muscle, and then posteriorly have the middle scalene muscle. We can see very nicely here the brachial plexus. This is the phrenic nerve that goes just over the anterior scalene muscle. So those are important anatomical structures to take into consideration. Also, we have here inferiorly to the omohyoid, we also have the thoracic duct right there in the confluence between the subclavian vein and the internal jugular vein in this location. This is a close-up view of this dissection in which we can clearly see the omohyoid muscle, the sternocleidomastoid muscle that has been retracted as well, and all the venous anatomical structures that are surrounding these muscles of the neck, that are the anterior jugular vein, the external jugular vein, and the internal jugular vein. Here is a detailed view of the thoracic duct and the confluence of the veins in this angle. We can see better the brachial plexus, the anterior scalene muscle, and the middle posterior scalene muscle. This is a picture with the sternum and the clavicle that have been divided, and then we see the subclavian vein very well, and the origin of the anterior jugular vein. We can see also the thyroid gland and the prethyroid muscles that we have divided and retracted here, and how the ansa cervicalis innervates these muscles in the neck. This is a surgical anatomy view from superior to inferior. So this is anterior and this is posterior, where we can see clearly the thoracic duct, and we have a nice view of the anterior scalene muscle and the phrenic nerve over it, with immediately posterior to it, we have the brachial plexus. So here is another view of the posterior triangle of the neck. And then we see many of the branches of the cervical plexus. And this is Erb's point, where we can see the confluence of these branches of the cervical plexus. We have the transverse cervical nerve, the supraclavicular nerves here. We also have, this is a posterior view of this point called Erb's point, which is about in the posterior aspect of the sternocleidomastoid muscle, about, it is about, mid-distance from the origin and the other insertion. And then we can see the greater auricular nerve here, and then the supraclavicular nerves as well. We can also see the lesser occipital nerve that comes here posteriorly. And then that's another view laterally of this area of the many branches of the cervical plexus. This is a close-up view of that cervical plexus, and we can also see this is the 11th cranial nerve running also posteriorly, very close to these other nerves from the brachial plexus. We can also see here the branches of the facial nerve coming in between both lobes of the parotid gland. This is a lateral view just to see better the carotid artery that is related anteriorly to the vagus nerve, which is located here, and we have retracted the internal jugular vein. This is another view posteriorly of the vascular structures, the relationship between the branches of the cervical plexus and the carotid bifurcation, and then laterally retracted the internal jugular vein. The posterior cervical region is covered by the trapezius muscle, and we have the superficial layer, the same layer, we can see the trapezius, and then here we see the posterior insertion of the sternocleidomastoid muscle, and then the next layer down is the splenius cavities, and here of note we can see the greater occipital and the lesser occipital nerves. Once we divide and dissect the trapezius and the splenius, we are faced with the semispinous cavities that if it's dissected and retracted laterally, we can see the suboccipital triangle. The reason why this suboccipital triangle is very important is because in the center of this triangle, we have the vertebral artery over the sulcus arteriosus of T1. The boundaries of these are the superior oblique, the inferior oblique muscle, and the posterior rectus muscle, the major here, and the posterior rectus minor muscle, which is here, which is not part of the suboccipital triangle. There's a very rich venous plexus, the suboccipital plexus around the vertebral artery. And if we retract the muscle, we can see very well the vertebral artery in the center. And this is the ramus of C1 that goes really close to the vertebral artery in this segment. Here in one side, we can see it not dissected, and here completely dissected, and we can see the vertebral artery. And then we can also see here the occipital artery that has anastomosis with the vertebral artery, as well as the deep cervical artery that provides vascularization to all these muscles. This is the greater occipital nerve as it comes from C2. And again, we can see a deep and rich venous plexus around the vertebral artery. And this is the vertebral artery as well. This is a close-up view of the vertebral artery and its anastomosis, which are quite frequent between the muscular branches, and also anastomosis between the occipital artery. And those are important to take into consideration during surgery because they can be damaged and it's a very copious bleeding because it's also coming from the vertebral artery. Here's a dissection down almost to the bone with only some insertions of the muscle left where we can see the spine posteriorly. And here we can see really well C2, that area of C2 with its nerve, the anterior ramus and the posterior ramus that gives the greater occipital nerve. This is a closer view of the anterior ramus that goes around the vertebral artery in the segment just lateral to the C1, C2 junction, and then this is posteriorly forming the greater occipital. This is a closer view of the occipito-cervical junction, in which we can see the junction here between the condyle, the occipital condyle, and C1, and then the articulation between C1 and C2 laterally, and the relationship of these with the vertebral artery. Here, we have exposed the dura posteriorly, just to show now the neural elements, the cerebellum and the spinal cord, as well as the arachnoid and the dura mater that has been contracted. Now we're going to start with some notes, journal notes about the facial anatomy. The muscles of the face, there are many muscles. We're going to discuss the most relevant muscles that are in the superficial plane. The one that this is the frontalis belly of the fronto-occipitalis muscle. Has a frontal and an occipital aspect of it, or belly. And then we have the orbicularis oris, the corrugator supercilii, the elevators, and then we have the zygomaticus minor and major, and the orbicularis oris right here, the depressor of the angle of the lip as well. And then we can see all the innervation through the little branches of the facial nerve. The temporal branches that go towards the belly, the frontal belly of the fronto-occipitalis muscle, then the branches, the zygomatic branches that go to this area towards the orbicularis oris. This is a frontal view of this anatomy where we can see the orbicularis oculi and oris, zygomaticus major, minor, the depressor, anguli oris, mentalis here, and this is part of the platysma. We can see in a deeper plane, deeper to the branches of the facial nerve, we can see the masseter. We can also see, importantly, this is the superficial temporal artery, the anterior and the posterior branches. We have some deep musculature here in the face that we are looking at, but this is to look at the vascularization of through the facial artery and vein and all their branches. This is a close-up view looking at the anastomosis also between the trigeminal branches of the trigeminal nerve and the facial nerve. Here, the infraorbital nerve anastomosis with some branches of the facial nerve. So this is a view of the temporal area on the right side. This is to explain the layers that form the fascia of around the temporalis muscle. So posteriorly, we only have one layer of fascia, but anteriorly, about 2 centimeters posterior to the orbital rim, the fascia divides into two layers: the deep temporalis fascia and the superficial temporalis fascia. In between, we have a 5 path. So the facial nerve branches that go to the frontal belly of the front occipitalis muscle, they go superior to the superficial layer of the fascia. So any dissection that is either interfascial or subfascial dissection is going to protect these branches. So this is a deeper dissection of the muscles, and this is the temporalis muscle, and here is the masseter muscle. We can see the attachment of the masseter muscle to the zygoma. If we remove the masseter muscle, and we also remove part of the mandible, we can see the deeper plane, and we would be inside the infratemporal fossa. We can see the buccinator muscle, and this is the part of the parotid duct that is divided here. So this is a better view of the insertion of the pterygoid muscles into the medial aspect of the mandible. So now going a little bit deeper to the temporalis, to the infratemporal fossa. These are the pterygoid muscles that have been divided and retracted. The internal and the medial and lateral pterygoid muscles, and then we can see in a deeper plane we can visualize very well the digastric muscle, and then all the muscles that are attached to the styloid process that are in a deeper plane. An important anatomical structure here is to see the carotid artery, the external carotid artery divided into the terminal branches, the internal maxillary artery, and the superficial temporal artery. Here we can see more detail. We see the styloid muscles. And then we can also see the digastric muscle. Here also the branches of the third division of the trigeminal nerve coming out from the valley, which is located here. Then if we divide all these structures and we divide also the buccinator muscle, we have entered into the oral cavity where we can see the muscles that form the tongue and the base of the mouth. Here, as we can see very well, we can see all the way over the bifurcation of the carotid. This is the hypoglossal nerve and that integrates this anatomy. Here we can see also the lingual nerve and even the terminal branches of these, including the terminal branches of the lingual artery. So this is what I wanted to discuss today. And just to mention that most of these work I performed as a fellow of Dr. Roten in Gainesville many years ago. And this is dedicated also to Dr. Roten, who was a wonderful mentor and brilliant neurosurgeon and very kind human being who we will all remember. And thanks to him and his legacy, we were able to open the surgical anatomy Roten program at Mayo Clinic here, along with, this is the opening, along with his family. So I just wanted to mention this and acknowledge their contributions, and thank you very much for your attention.
I would like to thank the Maria for the detailed explanation of the head and neck anatomy. I think these are the one of the best photos of this area, and I think there is no questions. Professor Kibar, do you want to say anything about what Maria explained? Okay. If there's no questions, we can close the session. Nagiza, do you want to say something about presentations?
Okay, thank you so much. It's a brilliant presentation with detailed anatomy, and I think it is very important for all neurosurgeons, especially who are doing spine, vascular, and skull base, especially anterior anatomy is important for safe procedures, at least of ACDF, and the posterior anatomy for far lateral, extreme lateral approaches, and C1, C2 junction. So that is very detailed. Thank you so much.
Okay. I think we want to see all attendees in the next week. We must check the program for the next week. Next week, we will talk about the craniocervical junction anatomy and lateral canal anatomy, and Victor Hugo Perez will be with us, and Jati Patipan. See you next week.
Thank you so much.